Hello, my name is Stéphane Haulon. I am a professor of vascular surgery and head of the aortic center here in Marignane-Longue, which is part of the Groupe Hospitalier Paris Saint-Joseph. Welcome to our hybrid room, which is a GE Discovery IGS-7. We will perform a complex case today using all the features of our hybrid room. And let me show you a couple of images from the case. It is a 68-year-old woman which has a large 65 millimeter type 5 thoracoabdominal aneurysm. I'm going to slowly scroll through the images to show you that the proximal landing zone will be in the mid-descending thoracic aorta, and the distal landing zone will be below the renals here and above the IMA. Okay. So once the percutaneous approach has been performed with a ProGlide system on both sides, we now get the discovery over the patient. So we switch from the open or percutaneous mode to the endo mode, and we are first going to register the fusion mask. So for that purpose, we will do an AP fluoro and then a lateral fluoro. Donc vous l'avez mis en route. And I need to position the patient with the spine in the middle. So AP fluoro. Switch automatically to a lateral view. So this is a lateral view, and we position the spine in the middle. So this requires table height to be at 14 approximately. Now from table side, vas-y, fais-le. Justine is going to register the red image, which is the image from the spine from the pre-op CT, on top of the fluoro image. So first on the AP view, and then she's switching to the lateral view, and you will see that this process will last just a couple of seconds. Parfait. So once we're happy with the bone registration, we switch to this aortic view. This is just the outer line of the aorta, and you can see the blue circles are the origin of the target vessel. So the beginning of the procedure will be to try and access those very challenging target vessels, which are the celiac trunk and the right renal, to pre-stent them. And so with the fusion mask, I can position the table and the gantry, and also you can see on the fusion mask. So I have inserted a 20 French sheath in which I'm going to advance the a 16 French aptus sheath. Now we're going to switch to a celiac trunk best working position. So Justine is going to select from table side that best working position, and the system will automatically position itself, which will be RAO 72 degree. Now we're doing no fluoro, and I know that I need to get my table down to nicely position the my table, and to position the celiac trunk origin in the middle of my image. So I'm going to slightly increase the image size. So this is a digital zoom. It doesn't require performing more radiation. Okay, parfait. Elle peut respirer. So you see that we are actually not bad with our fast fusion registration, but we're going to fine-tune that. And this is what Justine is now doing, again from table side. And this is now perfectly matched. You can see the origin of the celiac trunk, the origin of the SMA are nicely positioned. So I think we are now inside the celiac trunk. So I'm going to advance my catheter and then shoot a small angio. Wow, it's very tight stenosis. Let me shoot a small angio to check where I am. Il faut surtout pas que tu lâches, hein? Well, not an angio actually, I'm just going to do a fluoro. There you are. Tu vas storer, s'il te plaît? I can store this fluoro from table side. So I'm going to try and advance a B-Smooth 718, so a balloon expandable cobalt chrome stent inside the origin of the celiac trunk. You can see here it tracks well, so it has a very nice profile. I'm going to move that slightly higher. Tu peux le tenir comme ça, s'il te plaît? And now Justine is going to open the stent. Vas-y. Very nice. Et tiens ça, s'il te plaît. Et tu dégonfles. So you see on the review mode that the stent is nicely positioned just at the origin of the celiac trunk, and we have reopened the celiac trunk. So I'm quite happy with this first step. So I'm going to get rid of the rosin wire here, and now we are going to straighten the abscess sheath, and we're going to go down and try and access the tu peux enlever ça, the left renals. Again, a collimation is performed on the fusion mask in order to really focus on the area of interest. And here Justine is slightly enlarging the image, and then to advance into the renal artery. So let me check that it's the renal artery here. I really have no doubt, but I prefer to double check. So this looks like a renal artery. Tu peux storer, s'il te plaît? I'm going to advance a rosin wire, and then I'm going to shoot an angio and decide whether I need. I see that what looked like quite a significant narrowing on the pre-op CT is actually not that bad. So I'd rather not stent, not pre-stent that renal artery, because then it might become more difficult to advance the bridging stent once the endograft will be in position. So I will not do anything more on this renal at this stage. So I'm going to start releasing the endograft. Vous m'avez fermé ça, non? So the celiac trunk has open at 1 o'clock, the SMA at 12. The right renal artery should open at 9:30, and the left renal fenestration should be at 3 o'clock. So I need to do some slight rotation so that I position. You can see at the bottom of the image the two lateral markers of the left fenestration at 3 o'clock. There we are. Let me see if I can track my catheter over my Terumo wire. Yes, we can. So I'm advancing my bridging stent inside my 6 French sheath into the left renal artery. The best working position for the celiac trunk, and advancing now the system automatically into a 72-degree RIO, which is supposed to be the best position to access the celiac trunk. Elle peut respirer, merci. So I think that if we position the bridging stent inside the previous stent, I think we're perfect. Slowly advancing the bridging stent through that kink. So Justine will, c'est bon, je vais prendre. Justine will inflate the BEVAR Plus to 10 atmosphere. Tu peux nous donner un ballon de 9,2 sur porteur long, s'il te plaît? So it really looks good, and we have approximately between 15 and 20 millimeter of bridging stent inside the target vessel. So I'm very happy with that. Going down and then rotating again clockwise to position the tip of the sheath, hopefully in front, merci, of the SMA fenestration. Now we are through the branch, you can see, and I'm advancing my catheter, and I'm going to get now the aptus sheath at the level of the branch. Voilà. The wall, you see, I know exactly where I need to go because I have this marker contour of the origin of the SMA. You would think that I cannot miss it, but remember, we are in the middle of a very large sac. Now we are in the SMA. I'm putting the aptus sheath through the branch in order to be able to advance the 790 sheath into the SMA. Okay, no doubt that I'm in the SMA. Peut respirer, merci. I'm gonna try and advance again slowly in the bridging stent, which really tracks well. Slowly. There we are. How useful those markers are. I know that I'm a bit short into the target vessel, so I'm going to right away position a second bridging stent distally, which is something, information you would not have without the fusion mask. Okay, that's perfect. Sometimes you need luck, and I think looks pretty good. Let me double check where I am. Well, this seems to be the right kidney. Now Justine's going to deflate the balloon, and I'm going to advance the sheath back inside. Rotation. Perfect. So we are now looking at the 3D CT, the cone beam CT that we just acquired. And as you can see here, we have a very good, satisfactory image quality to check the endograft and the bridging stent. So the celiac trunk here, the SMA now, the right renal artery here, and then the left renal fenestration. And now I'm going to move to a sagittal view. And I can see that my bridging stents are very nicely positioned. And you see right away I have a 3D image of my reconstruction. I can see the nice overlap here. I can see also the nice overlap in the celiac trunk. The nice position of the stent protruding inside the aortic lumen for the left renal fenestration, and a nice anatomy of the right renal bridging stent. Now finally, just to double check the position of the fenestration, you can see that the renal fenestration really looks good, and I see my stent protruding in the aortic lumen. So we're done. Very happy with the result.
Hello, welcome in Genoa. My name is Giovanni Pratesi. I am a professor of vascular surgery and head of the Clinic of Vascular and Endovascular Surgery at the Ospedale Policlinico San Martino, University of Genoa. I thank the GE for the opportunity to present a clinical case today from our new hybrid room setting, which has recently opened last summer and is fully equipped with a new generation of discovery system. So this is the case we are going to treat. Is about a carotid artery stenting treatment. The patient is a male patient, 56 years old, affected by right severe asymptomatic internal carotid artery stenosis, already treated with the left carotid arterectomy, with multiple atherosclerotic risk factors. Regarding the planning in our protocol is to perform preoperative CAT scan for all our patients in order to appropriately plan the procedure. Using the dedicated vessel assist software from GE Workstation, the AWL Workstation, as you can see, is very easily to directly perform your planning of the procedure right before starting the procedure itself. And with just one click, you can easily segment all the interested vessel. As you can see here, we are now putting some marker at the level of the origin of the innominate artery in the aortic arch, as well as at the level of the origin of internal carotid artery. So here we are live in our hybrid room. You can see that with the using of our OneView broadcasting system, you can share and putting together the live image, the fusion image, and the camera of the room. You can see on the right you have the 3D model, which can easily use as a natural road map, the marker at the origin of the innominate artery, and you can see that the guiding catheter, in this case a multi-purpose guiding sheet, can easily follow this anatomic roadmap, selectively cannulate the innominate artery and also the common carotid artery. All these protocol can easily activate directly from the joystick at the table of the room. You can see that the guiding sheet is right now into the common carotid artery. We perform a short contrast injection for a perfect fine tuning overlay of the angiographic image and also the fusion image, and you can see the perfect alignment of both images. Now we are ready to cross the lesion. You can see that we are advancing our filter system. This specific case is an EZ filter wire. The crossing of the lesion at the origin of the internal carotid artery at the level of the marker. Again, the appropriate correspondence between the two images. Now we are ready to open the filter into the distal internal carotid artery. The filter is open, and now we are retrieving the protective delivery system of the filter wire, and we are ready to perform the stent, to advance the stent itself. You can see this is the digital zoom, which allow to increase the field of view without increase the exposure, dose exposure for the patient. And now we are very smoothly advancing the stent, and which is crossing the origin of the internal carotid artery. In this specific case is a road saver stent. We now are using a single shot just to confirm, to have a more appropriate and high definition images to identify the proximal and distal marker of the stent itself. When we go back live, we can see that the stent is opening with a pullback maneuver. This is a very smooth procedure, especially at the level of the origin of the internal carotid artery. Very accurate deployment of the stent. You see, we can, and this is something that is always important to prevent, is just to opening rapidly the stent itself, just to prevent any damage against the wall of the common carotid artery itself. Now we're retrieving the delivery system, and again we can once more perform a single shot. Here we are. You can see very easily with the high definition all the marker of this specific stent, which has some additional marker both at the proximal and distal ending. You can see also the specific design of the mesh, very high definition to see how the coverage of the plaque of the stent itself. Now my colleagues are ready to inflate the balloon to perform a post-dilatation balloon. We are using a small and rapid exchange balloon, 5 millimeters diameter by 20 millimeters in length, and the stent is now fully open, as you can see in the live image just shown. So we are checking the consciousness of the patient, and we are talking with him to see that everything is fine, and we are ready to perform the angiographic control, the final angiographic control. So first of all, we look at the location and patency of the stent, the absence of any issue at the level of the segment treated with the stent, but also at the level of the intracranial vessel itself. And as always, we perform intracranial control both in a lateral view, and this is the image we obtain in this specific case with all normal vessel representation, and also an additional control in AP view for better identify all the intracranial circulation, like in this case, you can see here the intracranial regular patency of the intracranial vessels. We can also additionally perform a 3D angiography using the specific software of our system Discovery 740. As you can see here, the 3D angiography allow to perform a dynamic evaluation of the intracranial circulation, and then using the dedicated software, the 3D volume viewer, is possible to reanalyze all the images on different plane. You can have the volume rendering, 3D volume rendering imaging, as well as the axial, coronal, and sagittal plane. This is particularly useful in the aortic segment, as we have already seen, but also in this kind of procedure, you can perfectly analyze the wall position of the stent at the level of the carotid plaque, as well as all the intracranial circulation. The wide bore with this particular system of GE, due to the distance between detector and source, allowed to cover a large field. This is particularly important when we perform abdominal 3D combined CT scan, but also when we use this kind of feature at the level of the neck itself. You see that now you can reanalyze by rotating the 3D volume rendering reconstruction of your carotid artery, and again, an additional features that allow you to more appropriately evaluate the results of your procedure, increasing the effectiveness of new technique of imaging, which now can be concentrated and combined in the same machine.
Hi everybody, thank you for the kind invitation, and I would like to thank the GE for the organization of this nice symposium. My topic is procedure spectrum performed in a hybrid room in less than 1 year. I'm Theodosios Bisdas. I'm a vascular surgeon here in Athens Medical Center in Greece. Here are my conflicts of interest, and just to show you again the location of our work. We are in Athens, in the beautiful city of Athens, and this is the Athens Medical Center, one of the biggest private hospitals in Greece, where we have built 1 year ago our first hybrid room, and this is, let's say, the feedback after 1 year of a very nice program in vascular medicine. So this is the hybrid room, the Discovery IGS-7, and you know, everybody knows this, and this is the place where we're working, a very nice hybrid room where we have developed all these standard, let's say, programs for the aorta, for the peripheral, and also for the veins. The spectrum that we are covering starts from the complex and simple aortic interventions. It goes to the advanced PAD, CLI, and visceral arteries. Then we are going to the carotid artery disease. And finally, we are covering also the deep vein thrombosis and pulmonary embolism. In this presentation, I will go through all these disease through presentation of different case examples. Now let's start with the complex aortic. What we are doing is that we are working a lot with the aortic arch program. At the moment we have available off-the-shelf techniques, but also we have available the new devices from CryoLife, and at the moment we are working very closely to our heart surgeons. This is a case of a covered rupture of an aortic arch aneurysm. It was an 87-year-old male, and we didn't have any time for any custom-made device, so we went for a total endovascular repair with a BEVAR procedure with an excellent result at the end. This is the video before and after the reconstruction, with a very nice result of total endovascular repair. Regarding the thoracoabdominal aorta, we are covering type B dissections, thoracic aortic aneurysm, post-dissection TAAAs, de novo thoracoabdominal aortic aneurysms. We have worked a lot with the cardiac surgeons for aortic isthmus stenosis, and we have done rupture TAAAs. This is a very difficult case that we have treated, a ruptured thoracoabdominal aortic aneurysm with the Leriche syndrome. This patient has been treated for an aortic infection with veins. These veins were occluded, and you can see that the superior mesenteric artery is the main collateral to both limbs. A very difficult case because we didn't have access from femoral approach, so we decided to do let's say surgeon modified fenestrated device, and to perform the implantation of the device through a transbrachial approach. This is the way that we are working, we are planning, and we are designing the case. This was an 82 centimeter aneurysm. As you see, there was no option for an open repair. It was a difficult, hostile abdomen for a transabdominal access. So we decided to use the axillary and subclavian artery from the left side. We developed a surgeon-modified tube with 2 fenestrations for the SMA and the celiac trunk, and the small fenestration for the Adamkiewicz artery. This is a small video how we are working in our hybrid room. You can see the partial deployment of the Endurant tube, where we have already calculated the fenestrations of calculated the length of our fenestrations. Here is the 2 fenestrations, one for the SMA and one for the celiac trunk. We are opening the fenestrations, and then we are measuring that it is 8 millimeter in length. And here you can see the insertion, the introduction of the fenestrated endograft through an 18 French seat that has been introduced from a transbrachial approach. Amazing, let's say, imaging quality, and here the fusion imaging is of unique advantage for us in order to be very precise with the placement of the fenestrated device. We're just opening here very carefully. We are inserting the bridging stent grafts to the fenestrations, and by this way we have a final really nice outcome with complete exclusion of the aneurysm. You can see there is no contrast agent inside. This is the 3D reconstruction, and in the follow CT scan, you can see a nice regression of the aneurysm sac. Another case example where we have a great advantage, let's say that we were in the hybrid room, because we had to do cut downs in both carotid arteries and axillary artery. This was an aneurysm after a dissection. You can see an almost 8 centimeter aneurysm of the abdominal aorta, with aneurysm also of the common iliac artery. Symptomatic, he had abdominal pain. This patient, very difficult to treat because we had to go for an off-the-shelf quick solution. You can see here the diameters of the thoracic aorta and of the abdominal aorta. The right renal artery was from the false lumen, and the left renal artery from the true lumen. And here was the right hypogastric artery. You can see is below it's at the level, let's say, of the big re-entry of the false lumen. So we had to also treat the common iliac artery. What we have done, a combined chimney and periscope technique in order to have the ability for a transaxillary approach for a multi-branch endograft. The first stage was repair the aortic arch, and here you can see nicely the final placement of the thoracic endograft at the level of the aortic arch. And this is the angiogram where we have a nice placement of all devices and a nice perfusion of the left subclavian artery. This was the preparation of the next stage. You can see the reconstruction, further tapering of the thoracic endografts in order to prepare the place of for an implantation of a thoracoabdominal branched endograft. In the second stage, we performed an endovascular TAAA repair with a T branch from Cook Medical, the unibody and the iliac side branch. This is the iliac side branch at the level of the right hypogastric artery. We have connected already the SMA and then the left renal artery. Again, fusion imaging of unique importance here in order to be very precisely with the placement. And then we have done a very nice trick. We have used the re-entry catheter outlet from Cordis in order to introduce the wire from the true lumen to the false lumen. At that level, we are penetrating more or less the membrane. Here you can see the catheter now is the false lumen, and we could connect the right renal artery to the branched endograft. Final, the use of the iliac side branch, and we use here, and this is unique due to the enough space that we have in our hybrid room, we are using also sensomotory evoked potential in order to be sure before the completion of the procedure and I mean before the total exclusion of the aneurysm, we are performing evoked potential, and in case of a normal response, we are really using the final bridging stent graft. This is the CT scan and the postoperative day 4 with a really amazing, let's say, exclusion of the whole aneurysm after a type A dissection. Again, 3D reconstruction and the full metal jacket in this patient. Another case example, suprarenal TAAA with a symptomatic suprarenal aneurysm after a migration of a talent prosthesis. Very nice result at the end. However, here of unique importance in the fenestrated grafts, as also Stefan Haulon many times showed in his publications, we can appreciate the placement of the stents, any kind of adverse events, and in case that we have something like this, we can treat on time without the need of a new, let's say, access. We have already the devices in the seats in place. Visceral arteries, another spectrum that it is very important for us to cover aneurysms of the superior mesenteric and hepatic artery, stenosis, type 2 embolic embolization, tumor embolization, or even embolization of the hemorrhoidal arteries. This is a case of a post-pancreatitis aneurysm of the hepatic artery in the SMA. You can appreciate the aneurysm of the hepatic artery and also the post-dissection aneurysm of the SMA. A very challenging case that was treated very nicely by endovascular means with a covered stent for the hepatic artery and embolization of the false lumen of the SMA with using of uncovered stents up to the branches of the SMA. This is the final result with really full treatment and a successful treatment of both aneurysms. This is the CT scan at the discharge. The deep vein thrombosis and pulmonary embolism is a trend at the moment in the vascular medicine. This is a case of a chronic DVT with postthrombotic syndrome. In that cases, we have the ability to go with barrel technique with double wires and to have a really nice result at the end. And this is the result before and after the treatment. This is a classical postthrombotic syndrome with massive ulceration, which was really treated very quickly, and the ulcer was healed successfully. We have started also our PE program in the framework of the so-called PERT team. This is a case of a massive pulmonary embolism. After 10 minutes of systemic thrombolysis, we have a massive hematoma of the face due to the fact that the patient fell down in her home, and in that case we have successful recanalization of the right pulmonary artery. We stop the thrombolysis and we have a nice result with, you can see here, with contrasting the distal, let's say, branches of the right pulmonary artery. The peripheral arterial disease is one of the biggest, as I say, portfolio in our practice. Complex FEMPOP disease, complex BTK disease, and venous arterialization. We know that vessel preparation is the gold standard for a nice and long-term result in, let's say, in the right treatment of peripheral arterial disease. We're using a lot the directional atherectomy device, and with excellent results and removal of the plaque. The hybrid room provides us all these important imaging that we need for a successful treatment, or this kind of hybrid atherectomy, that means rotational and directional atherectomy. This is the Phoenix device from Philips with a nice vessel preparation, a nice result after angioplasty with a drug-coated balloon. Intravascular lithoplasty is available in our program. This is the Shockwave, the so-called Shockwave balloon, that it uses really pulses to let's say, to break the calcium. This is for severe calcified lesions like this one here in the SFA, with an amazing result at the end without the need of stenting. The retrograde puncture is a new trend and a current trend that we are using more and more, due to the fact that in our hybrid room we can have also all the abilities that the ultrasound devices from GE are providing, the excellent performance in order to treat really this kind of complex CLI cases. In that case, we had a severe gangrene. This patient was actually defined as a patient that needs major amputation, but due to the fact that we were able to do a nice procedure, we were able to perform a minor amputation and then to perform a nice grafting of the skin on the forefoot, and with an excellent result at the end. So no major amputation was necessary. Another difficult, very difficult cases. Again, this case was really scheduled for a major amputation. However, due to the fact that we performed a very good, let's say, angiogram, in this angiogram, someone can appreciate that everything is open. We have a very good, let's say, a very good revascularization, and we have good vessels up to the forefoot. However, if you can appreciate, we have opened the peroneal artery that gives exactly this kind of vessels that we want at the level of the gangrene. However, with this kind of spectroscopy that we have as a tool in our hybrid room, we can really appreciate the fate of the forefoot, because we now know that everything is much better after the revascularization. You can appreciate here the difference in the colors in the spectroscopy before and after the revascularization. And this led, of course, to a very nice result. Again, skin graft at the level of the debridement and a small and minor amputation. This patient is still walking at the moment. We are using CO2 in our patients, and this is a unique advantage that we have, and the software, the hybrid room, provides the ability to use CO2, and this is ideal in our patients with peripheral arterial disease and chronic kidney disease, but also with allergy to iodine. And what we have started now performing more and more is the so-called VAS technique. This is the technique where you are let's say, changing the nature of the distal veins from arteries to veins. That means you're doing a venous arterialization, and you're using the veins as a way to bring arterial blood into your forefoot. And you can see how nicely you can penetrate with two loops the artery and the vein, and by this way you are just performing directly this kind of anastomosis between vein and artery. By this way you are just implanting a covered stent up to the level of the forefoot, and then afterwards the veins do not have any kind of valves. You just need to perform a good vessel preparation, and then you have this amazing angiogram, as you can see on the left side. Here is the creation of the anastomosis, and you can see how you can use a Bernstein catheter and the loop of a soft terumo wire in order to find the right way. Then very good angioplasty of the veins. You can see here that you have a spasm of the veins, but at the end you need to go through the plantar loop of the vein system in order to have as closely as possible to the forefoot, to the distal part of the forefoot. You can have this kind of let's say, vein arterialization that you really need, and you can see how it changes over the days and what you had before and afterwards. And in the first post-operative day, you can hear pulses at the level of the tibial veins. This is the leg, the forefoot before, after the minor amputation, and the final result after vein arterialization. So in conclusions, ladies and gentlemen, the hybrid room provides unique features for all type of interventions and for all vascular territories. The spectrum consists mainly of complex aortic interventions, carotid artery interventions, visceral artery disease, and PAD interventions. Confidence in case need for open conversions is really clear. We have less radiation, and this was proven in several papers due to fusion imaging. Imaging-guided therapy, due to the fact that we have not only the hybrid room, but we have all these features that GE provides, from this ultrasound up to the CT scan, and several other features are optimizing the daily practice of the vascular specialist. And it is a unique place for multidisciplinary approaches, like in cases of coexistence of cardiac and vascular surgeons, or even in case of embolization of tumors between general surgeons and vascular specialists. Thank you very much for your attention.